Good afternoon. Thank you very much for inviting me, and thank you for the introduction. I'm now going to discuss the cons of testing for hepatitis C virus resistance in clinical practice. This slide shows my conflict of interest disclosure. However, I have another conflict of interest to disclose, which is that I systematically do RAS testing before retreating patients who are exposed. However, I believe that it is possible to retreat with very high efficacy without doing it. The first point I want to discuss today is that we can avoid treatment failures by following strictly the final update of the EASL recommendations on treatment of hepatitis C. The Simplified treatment strategy has been published together with the recommendations. It's the last issue of the Journal of Hepatology, and you can see here that it's possible to treat very simply without doing genotyping or subtyping, either with glecaprevir pibrentasvir for 8 weeks or 12 weeks in patients who have cirrhosis and are treatment experienced, or with sofosbuvir and velpatasvir for 12 weeks. With this treatment, you will have very high SVR rates and very few patients who will fail on therapy. It is, however, possible to treat even better if you have access to genotyping, subtyping, and in the guidelines, it's clearly explained that reinforced strategies may further improve the SVR rates in patients who are more difficult to cure, patients who are infected with genotype 3 who have cirrhosis, and patients who are infected with genotypes or subtypes that are inherently resistant to hepatitis C virus DAAs. And this includes genotypes, subtypes that are present in some countries in Africa and Asia, and are also present in Europe in patients who are born in these areas. So the recommendation which is currently made for RAS testing in the EASL recommendations is the following: HIV resistance testing prior to retreatment in patients who failed after any of the DA containing regimens is useful to guide retreatment by probabilities of response according to the resistance profile observed. This means that it is useful, but not that it's absolutely mandatory. And this is what I would like to discuss now. First of all, there are technical reasons not to use RAS testing prior to retreatment. The reasons are shown here. RAS testing is unavailable to the vast majority of HIV treaters, and this is particularly important in the context of extending the treater pool. More treaters mean more people do not have access to RAS testing. In addition, there is no standardization of RAS testing. Only one NGS-based standardized assay is currently available as a purchasable kit. Otherwise, it's only in-house sequencing methods that can be used, and many places don't have access to these methods. There is no standardized interpretation and reporting of HIV resistance data, and there are no clear-cut guidelines from international societies to guide treatment decisions based on RAS testing. The third point I want to make is that how to use RAS profiles prior to retreatment is pretty unclear. Indeed, there are two options. The first one is that treatment has not been optimal. It can be a treatment that has been given before the most recent recommendations at the time when the most recent DAs were not available, inappropriate choice of drugs, too short duration, poor adherence to therapy, all reasons to have a non-optimal treatment. And in that case, the RASes that will be present are highly predictable. So you can guess based on what the patient has received, what RASes will be present, and you don't really need to test for that. And then optimal retreatment strategies are likely to be highly efficacious based on this prediction of the RASes that are present. The second option is that you have followed the most recent EASL guidelines and treatment has been optimal. The patients have received pangenotypic regimen for the appropriate duration. In that case, the RASes that will be selected are very difficult to predict, and they are poorly predictive of retreatment outcomes. And therefore, the RAS profile in that case of optimal treatment and rare but possible failure will be very difficult to make. Just to illustrate this point, I want to show you the rates of failures that can be observed with sofosbuvir or velpatasvir. It's a pool resistance analysis from phase 3 trials. You can see here that approximately 1% only of patients fail with RAS selected. The vast majority of them are in the group of patients with genotype 3, 2.5%, followed by genotype 1. And if we look at the RAS profiles observed in these patients, for genotype 1, you see different types of resistant substitutions selected in the NS5A region, Q30R, L31M, Y93N, Y93H, which are not really strongly predictive of what drug should be given. And we know that the triple combination is very likely to achieve an SVR in these patients. We have selected these RASes. And for genotype 3, the most frequent RASes were the A30K, the Y93H, but again, very poor predictive value on what retreatment should be given and the outcome of retreatment. The same applies to the combination of glecaprevir pibrentasvir, and you can see here that the rate of failure is approximately the same, approximately 1% overall, vast majority again in patients infected with genotype 3, 2.8%, and less frequent in other genotypes. And here, again, we have a lot of different RAS profiles. They are different for genotype 1, genotype 2, and genotype 3, with different types of RASes, no homogeneous profile, and RASes selected in both the protease region, which is a target of glecaprevir, and in the NS5A region, which is a target of pibrentasvir. Nothing that can be used to say strictly this RAS predicts that the patient will need to be treated with this treatment or that other treatment and will surely respond. And therefore, this is not very useful to make a decision of retreatment. So the final point I want to make, and which is most important here, is that there are excellent retreatment options regardless of RAS profiles at retreatment baseline. These retreatment options have been listed again in the most recent EASL recommendations on treatment of hepatitis C. They include the triple combination of sofosbuvir, velpatasvir, and voxilaprevir, the triple combination of sofosbuvir plus glecaprevir and pibrentasvir, Sovelvox or sof plus glecaprevir pibrentasvir with ribavirin, and it's also possible to extend treatment duration of the triple combination with or without ribavirin from 12 to 16 or 24 weeks in very difficult to cure patients. And we know that these retreatment regimens are very efficacious. We have results with sofosbuvir, velpatasvir, voxilaprevir in 2 clinical trials, phase 3 clinical trials in patients infected with all genotypes. They experience approximately half of them with cirrhosis. On the left, the Polaris-1 trial, NS5A experienced patients retreated for 12 weeks with sofosbuvir, velpatasvir, voxilaprevir with a 96% SVR rate, only 6 relapses and 1 breakthrough. And on the right, the Polaris-4 trial, which was in DA experienced but NS5A naive. They had been treated with other DAAs, and the SVR rate here is 97% with only 1 relapse. If we now look at the influence of pre-existing RASes on treatment responses in these 2 trials, this is a pooled analysis of Polaris 1 and 4 in these treatment experienced patients. You can see on the left, all DA experienced patients, all patients from 2 trials, and the influence of the presence of RASes on retreatment response. On the left, 98% SVR12 in patients who had no RASes at all. And on the right, the very same SVR rate, 98% in patients who had different types of RASes in the NS3, NS5A, or NS3 plus NS5A region. On the right of the screen, you can see the role of voxilaprevir and velpatasvir specific RASes. And again, there was no influence of the presence or absence of RASes on the response to Sovelvox, meaning that this retreatment is very likely to achieve an SVR regardless of the presence of RASes selected during the first course of treatment at the time of retreatment. Same thing now for the combination of sofosbuvir plus glecaprevir pibrentasvir. It has been tested in a phase 2 trial, the Magellan 3 trial. It is patients from phase 2 and 3 trials who failed first GP treatment regimen were retreated with sofosbuvir plus GP. And as you can see here, the SVR rates here are very high with a 96% overall SVR rate. There was only 1 relapse in patients, in a patient who received sofosbuvir plus glecaprevir pibrentasvir plus ribavirin. So if we look at the final recommendations on treatment of hepatitis C, it is clearly said that based on the results of the Polaris trials, Sofosbuvir, velpatasvir, and voxilaprevir is the first-line retreatment strategy for any patient who failed a prior regimen with a DAA, with or without RAS, with or without RAS testing. There are potential reinforced strategies. A combination of sofosbuvir plus gilcaprevir, pabrentasvir is likely to have a higher, slightly higher barrier to resistance in the case of NS5A resistance, can be reserved to patients who have more advanced cirrhosis or other predictors of non-response to retreatment. And even reinforced strategies are available. These reinforced strategies include the combination of the 3 drugs, Sub-Velvox or Sub-GP, plus ribavirin, an extension of duration up to 24 weeks. And this is how we retreat our patients, either with Sub-Velvox first line or with more sophisticated reinforced strategies in patients who we think need a stronger, longer treatment. And so far, this has been extremely successful. In the past 6 years, I think we have retreated hundreds of patients and had only 2 retreatment failures in our experience. This brings me to my conclusion, and this conclusion is taken from the EASL recommendations, literally, and the retreatment in the recommendations must be guided either by the knowledge of which drugs were administered in previous treatment courses. If no resistant test is available, that will be the majority of cases where no resistant test is available, or, and this is what we do in my place, but it's a special place, if resistant testing is performed by probabilities of response according to the resistant profile observed and the treating team's experience. This is a plus, but again, it is not absolutely necessary. On this, I thank you very much for your attention.